Have you ever stopped to think about what really makes a hospital or a big medical center tick? I mean, beyond the doctors and nurses you actually see. It's this huge, complex machine, right? Today, we're doing a deep dive into something really foundational. We're looking at the NHRA Accreditation Standards for medical centers, and specifically, we're zooming in on workforce management. Now, NHRA, that's the National Health Regulatory Authority, and they set some seriously high standards for healthcare in Bahrain.
That's right. And we've been digging into their detailed document from November 2023. What we found is, well, it's much more than just a checklist. It's really a blueprint for how these places manage their most critical resource, their people.
Yeah, exactly. So our mission today is to kind of unpack these standards. We want to show you the surprising level of detail, the real meticulousness involved in managing the human side of a medical center. We'll explore why this stuff matters so much, not just for, ticking boxes, but for patient safety and for the staff's own well-being. It's a shortcut to getting informed on something vital.
Okay, let's dive in then. When we talk about managing this whole workforce, where did these standards even begin? What's like the first step?
Well, the starting point, element 2.1, really sets the strategic foundation. It kicks off by requiring a specific named senior staff member. Standard 2.1.1 says this person has documented responsibility for the entire workforce and all the HR functions.
Ah, okay. So one person with clear accountability.
Exactly. It's not just a vague responsibility floating around, it's assigned. And their job includes implementing and monitoring all the relevant policies.
Makes sense. And it's not just about having a person in charge, right? The outline mentioned a plan for staffing. How detailed are we talking? Oh, it gets very detailed. And this is fascinating, actually. Standard 2.1.2 mandates a current written staffing plan. This isn't just a wish list. It has to be developed and reviewed by the leadership team.
Okay.
And here's the important part. It has to link directly to the medical center's overall business plan. And it must explicitly spell out how they'll staff the place to ensure both patient safety and staff well-being. That connection is key.
Patient safety and staff well-being right from the planning stage.
Precisely. It forces that integration. And the plan itself, it covers everything. You're looking at skills needed, qualifications, grades, the specific licenses for healthcare professionals. Then there's workforce planning, working hours, shift patterns, on-call duties. Plus, employee health and welfare, pay and reward systems, and, critically important nowadays, workforce contingency planning for emergencies. Think pandemics, major incidents. They even have to monitor workloads.
Wow, that is incredibly comprehensive. It sounds like they have to think of almost everything. So how does this detailed planning connect to actual training for the staff?
It flows directly into it. Standard 2.1.3 requires a documented training and development plan. And this plan has to be written in accordance with that staffing plan we just discussed.
Ah, okay, so they link up.
They have to. It identifies the training needs across the entire center. This includes keeping professionals updated, training for new practices or laws, new equipment, new tech. And importantly, it incorporates needs that come out of the performance review system. It's a cycle.
And what about the basic rules, the HR policies?
Right, that's standard 2.1.4. They need solid human resource management policies and procedures. These have to meet current needs and comply with all the relevant laws, local, national, international.
So the standard stuff like recruitment.
Yeah, recruitment, selection, terms and conditions of employment, disciplinary processes, grievance procedures, and how performance reviews are handled. It provides that essential framework for fairness and clarity.
Okay, now here's something I found really interesting in the outline. What about the tougher stuff? Staff complaints or, issues like bullying or difficult behavior.
Yeah, they tackle that head on. Standard 2.1.6 mandates documented policies and procedures for dealing with staff complaints, bullying, harassment, and challenging behavior. It's not just about having a policy. They have to document the follow-up actions taken.
That's quite specific.
It is. And the introduction to the standards actually notes that staff views are regularly sought out as a way to improve things. They treat staff like key stakeholders, which means creating channels for feedback, even difficult feedback.
So it's about creating a culture where people feel safe to speak up and issues are actually dealt with.
Exactly. It fosters a healthier, safer environment overall.
Okay, so we've got the big strategic plans, the core policies in place. How do the standards make sure that the right people, the properly qualified people, actually get hired and allowed to practice?
That brings us squarely into element 2.2, which is all about credentialing. Standard 2.2.1 lays out documented processes for the appointment of medical staff and granting clinical privileges.
Credentialing and clinical privileges. Can you break those down a bit?
Sure. Credentialing is basically the exhaustive process of verifying everything about a healthcare professional's background, their education, training, licenses, experience, competence. It happens before they're appointed.
Okay, the deep background check.
Pretty much. And clinical privileges are the specific permissions granted after credentialing. They define exactly what procedures or treatments that specific doctor, dentist, or other professional is allowed to perform within that medical center.
So it's very specific to the individual and the place.
Very specific.
Yeah.
And these processes have to follow NHRA guidelines and are reviewed every 2 years, so they stay current.
And I assume keeping those professional licenses up to date is a big part of this.
Absolutely critical, non-negotiable, really. Standard 2.2.2 requires evidence that all professional staff maintain a current license by the NHRA to work in the Kingdom of Bahrain.
Evidence me.
Meaning the medical center has to keep an active register, a list, of all the current professional licenses for every single healthcare professional they employ or contract with, full-time, part-time, even temporary locum staff. No license, no practice.
That seems like a pretty tight system.
Yeah.
What about the checks before they even get offered a job, those pre-employment checks?
Also very rigorous, Standard 2.2.3 details the documented procedures and systems for pre-employment checks of all staff. And note, it says all staff.
Not just doctors and nurses.
Nope, everyone. The checks include verifying identity, checking the professional license again, verifying registration, qualifications, their defined scope of practice, training certificates, employment history, references, and occupational health checks too.
Wow.
And this applies to anyone applying for any job, even visiting specialists. It ensures a consistent level of vetting across the entire organization.
Okay, so they've passed the vetting, you know they're qualified. How do these standards make sure everyone then clearly understands their specific job and what's expected of them?
Right, that moves us into recruitment, which is element 2.3, and then induction. First up, job descriptions. Standard 2.3.1 requires a job description policy.
More than just a list of tasks, I hope.
Definitely. It mandates a specific format that outlines the required knowledge, skills, and attitude for the role. They have to be reviewed every 3 years or sooner if the job changes significantly, and every staff member gets a copy.
Sets the expectations clearly from the start.
Precisely. And then there are the contracts. Standard 2.3.2 states, all staff, clinical and non-clinical, have a signed contract which includes the terms and conditions of their employment.
And that covers.
The essentials. Working hours, shifts, including any on-call stuff, annual leave, sick leave, and importantly, their specific responsibilities and accountability. No gray areas.
Okay, so they're hired, the contract's signed, job description is clear. What happens when they actually walk in the door on day one? What's the welcome aboard process look like according to these standards? I imagine it's more than just showing them the coffee machine.
Yes, definitely more than that. This is element 2.4, induction. Standard 2.4.1 mandates a mandatory induction program for every single new employee.
Mandatory, okay. And they have to attend within a certain time.
Yes, within a specified time frame of starting, and their attendance is documented.
Now, the outline mentioned the breadth of this induction is quite something. Can you give us some examples? What sort of things are covered that might, surprise people?
It is surprisingly broad, much more than your typical HR orientation. Of course, you get the mission, vision, values, but then it dives deep into practicalities and safety. Like their specific role in disasters and emergencies, fire drills, evacuation procedures, information on hazardous materials, how to read material safety data sheets, standard infection control dress code, hand hygiene. Electrical safety.
Okay, lots of safety basics.
Yes, but also communication systems, how pagers work, phones, patient communication protocols, general info on performance reviews, risk management defining incidents, adverse events, sentinel events, and crucially, how to report them.
So empowering them to be part of the safety system.
Exactly. Also, how to handle patient complaints, an overview of credentialing, privileging, competency processes, quality improvement and patient safety, stressing staff involvement. Then there's information on expected ethical conduct and professional communication. That's a big one.
Setting the cultural tone.
Absolutely. And protecting patients' rights, privacy, and confidentiality. Finally, they get an induction specific to their actual role, and they're given all the relevant policies and have to sign off that they've understood them.
Wow.
Yeah.
Thorough doesn't quite cover it. It sounds like setting a very clear standard for safety, ethics, and operations from the absolute beginning.
That's precisely the goal. Everyone starts on the same page, understanding the height expectations.
Okay, so they're inducted, they understand the rules and the culture, but learning doesn't stop there, obviously. How do the standards ensure people keep developing and stay competent?
Right. That's where element 2.5 training comes in. After that initial induction, there's a mandatory ongoing training program. Again, mandatory, and for all staff.
All staff again. What kind of ongoing training are we talking about here? Is it just job-specific stuff?
Some is, but a lot is about reinforcing those core safety and professional standards. Think regular refreshers on fire safety, health and safety, manual handling techniques, infection control.
The essentials.
Yes, but also things like confidentiality of information. That's huge. System security, records management, data protection, secure sharing. Also ongoing training on patients' rights, patient-centered care approaches, and crucially, safeguarding training how to recognize signs of potential abuse or neglect.
That's vital.
Absolutely. And then, of course, any required life support training based on their role and license. And just like induction, all this training and its results are recorded in individual staff files.
Keeps everyone accountable. What about equipment? Technology changes so fast in healthcare.
Good point. Standard 2.5.2 specifically addresses that. It requires evidence that staff are trained in the safe operation of equipment. And it's not just initial training. They need tools or processes to ensure ongoing competency, especially as new equipment comes in.
Makes sense. You can't just train once on a complex device and assume proficiency forever.
Exactly.
Okay, so people are trained, they're kept up to date. How do these standards then loop back to make sure performance is actually meeting expectations and ideally continuously improving?
That leads us logically to element 2.6, performance review. Standard 2.6.1 says all staff, including clinical and non-clinical staff, undergo an individual performance review, appraisal, on a planned basis, usually annually.
And this isn't just a chat, right?
No, it's structured. It involves defined, agreed-upon objectives and timescales. It's meant to be a developmental tool, not just a judgment.
And do these reviews then feed back into that training plan we talked about earlier?
Yes, directly. That's the integration piece. Standard 2.6.2 states that upon completion of the performance review, an individual training and development plan is developed.
For each person.
For each person. Then the department heads or managers compile these individual needs and feed them up to leadership. Those needs then get incorporated into the overall medical center training plan we discussed back in 2.1.3.
So it closes the loop. Individual needs inform the big picture training strategy.
Precisely. It ensures training is relevant and targeted.
Now, what about medical staff specifically? Is their performance review process different or more rigorous?
It is. Standard 2.6.3 specifies that all medical staff undergo an annual performance appraisal by the medical director and departmental head to determine continued competence to provide patient care. It's very focused assessment of clinical competence.
Okay, continued competence.
Yeah.
What kind of metrics or data do they actually look at for doctors? It must be complex. Can you give some examples? Maybe some surprising ones.
It's definitely data-driven and goes deep into clinical practice. The evaluation looks at things like mortality and morbidity rates associated with their patients, outcomes of surgeries or procedures they perform.
Hard clinical outcomes.
Yes. Also, utilization patterns. Are they ordering appropriate tests and interventions? Medication usage, including error rates. They review medical records for completeness, timeliness, quality of patient assessments, and they look at adverse events related to the physician's care.
So it's not just subjective opinion. It's based on actual patient care data.
Very much so. It's about objective measures where possible, linked directly to patient care quality and safety. The focus on utilization, for instance, is quite sophisticated, looking at efficiency and appropriateness, not just activity.
What's the ultimate goal of gathering all this detailed, maybe sensitive performance data on medical staff?
It's explicitly for improvement. Standard 2.6.4 says the medical director uses this information as a means to continuously improve patient care.
How so? What actions might come out of it?
It could lead to several things, maybe counseling for the staff member, in some cases amending their clinical privileges, restricting certain procedures if competence isn't demonstrated. It might highlight variances in practice that need studying and correcting system-wide, or identify needs for new equipment, specific training, or refresher courses. It's also used to improve care processes generally, often working with the quality management team.
So it's a continuous quality improvement cycle fueled by performance data.
Exactly. A
Yeah.
powerful feedback loop.
Okay, we've covered a lot. Strategic planning, hiring, training, performance. But it strikes me that these standards also seem to really care about the people doing the work, their well-being. Is that right? How is that addressed?
You're absolutely right. It's not just about managing tasks. It's about nurturing the caregivers. This brings us to the final element we're covering, element 2.7, staff welfare. Standard 2.7.1 requires the medical center to have a plan and processes in place to address the health and safety of staff. This involves assessing and reducing occupational health risks.
Okay, occupational health. What does that actually include beyond, say, fire exits and safety signs?
It's quite comprehensive. It starts with pre-employment medical checks for new hires, including ensuring they have necessary immunizations. It covers how the center responds if an employee has a health problem providing treatment or referring them. It includes screening staff for exposure or immunity to relevant infectious diseases, procedures for managing exposure if it happens, like needle stick injuries, measures to reduce hazards, providing proper protective equipment, offering stress management support, ensuring good ergonomics to prevent strain.
Stress management and ergonomics. Interesting.
Yes, and educating staff about job-related hazards, safe lifting, equipment handling, how to spot and report risks. They also have to record and analyze any staff incidents, like injuries or illnesses, to figure out how to prevent them happening again.
So a proactive approach to keeping staff physically safe and healthy on the job.
Correct. But it goes even further.
Oh, how so?
Standard 2.7.2 talks about initiatives for lifestyle issues and promoting overall well-being.
Lifestyle issues. Like what?
The standard gives examples like smoking cessation programs, stress management workshops again, stress management, weight management support, access to counseling, promoting healthy eating, encouraging exercise, and even things like mindfulness programs.
Mindfulness. Wow. That's quite progressive for an accreditation standard.
It really is. It reflects a growing understanding that staff well-being, mental and emotional, not just physical, is crucial for sustainable, high-quality patient care. Burnout is a huge issue in healthcare.
Absolutely. So with all this focus on staff welfare and development, do their opinions actually count? Is there a mechanism to ensure staff views are heard and used for improvement?
Yes, very clearly. Standard 2.7.3 requires evidence that staff views and attitudes are monitored. Often this is through a staff satisfaction survey, but it can also be focus groups, suggestion boxes, things like that.
And the key is?
The key is that the findings must be used to make improvements. It can't just be a survey that sits on a shelf, and they have to gather these views from everyone, clinical, non-clinical, part-time staff, even volunteers where applicable.
So ensuring everyone has a voice, and that voice contributes to making the workplace better.
That's the intent. It reinforces that stakeholder idea we talked about earlier.
Okay, so let's try and wrap this up. We've walked through these NHRA standards for workforce management, and wow, it's clear that running a medical center safely and effectively is, well, it's an incredibly detailed and demanding job behind the scenes.
It really is.
It seems to be all about meticulous planning, really rigorous vetting of people, ongoing development for absolutely everyone, and maybe surprisingly, this deep commitment to the well-being of the staff themselves.
I think that's a great summary. And if you connect it to the bigger picture, what it really shows is that the quality of care you receive as a patient isn't just about that interaction with your doctor or nurse. It's deeply tied to every training session, every performance review, every effort made to support the staff. These standards paint a picture of a whole ecosystem. The health and the strength of the workforce, their